And to just to all the participants, as I mentioned in the group, there won't be any didactic today. I mean, like the first session, this is aimed at case-based discussions. You might have gone through the pain modules by this time. So we will be discussing a little bit on mostly case-based discussions on pain management and on ethics. So I understand for today there are no case presentations from your side, but we expect you to bring in the challenges that you face when you do pain management in your setting, and we can discuss it in this group. That's the whole idea of this interactive learning session. Over to you, Sanghamitra.
Hello, good evening, everyone. And thank you, Pallium India. Thank you, Sridevi. Thank you, Shripriya, for again bringing me to this platform. It is all the more interesting for me. And I really love these sessions because I get a chance to, revisit my modules once again. So I would like to first, have an interaction from the participants here. Let us be all be on one page and share, whatever problems you have faced while going through your pain module. And I think we are also going to discuss about medical ethics a little bit. I have a small PPT with me, not small, it's a big one, where, I will not show you all the details of the modules, but, at least some bit of it, some part of it, which is important. Very simple things that we actually forget to do when we, when there is a patient that needs our care. And so maybe you can start somebody who can volunteer to bring about a problem that you might have faced. You do not have to, elaborate, but then, of course, any kind of fact that you would like to share. So first 1 minute for that, and then we can proceed. Anybody who can share. So I can see Dr. Pankaj, Dr. Nilakshi, Dr. Samarth, Dr. Isha, Dr. Riddhi, Chandrika, Asha. I really don't want to, overload you with a lot of gyan today, but, maybe whatever you have faced, that would be a better thing to do. Dr. Pratna, Dr. Karthik. Yeah, Dr. Riddhi, you have raised your hand. Kindly tell us your problem.
Hello, hello, doctor. Good afternoon. I'm just reaching back home, so it's not. I'm just. So it wasn't for understanding the modules. I think it was initially got not confused because of the what to do and what not to do. But because we had the WhatsApp group, we could understand. Okay, we had to do 5 modules and the video. But it would for the first 2 modules, the courses was because it's written as courses and it's said as modules, so we got that also confused because there's no description what we are doing. But again, it was explained, so eventually could get through it. But it would be good that if we have the intimation that how much time it takes for one course, because approximately, and then we had an idea that 1.5 to 2 hours, but the 3, 4, 5 modules were quite short. They were I could complete it faster, in a half an hour to 45 minutes it was done. So I mean, I just wanted to say it would be good if we have an approximate duration so that we can have that time during our work hours also, because if it's 1.5 to 2 hours, then we have to invest more time. But if it's just 40 minutes, then
Great.
just coming after from work, we can just manage something.
Yeah, Sridevi, you would like to say something on that?
I would like to take the technical part or the this kind, I mean, the course related part in the end, because there were a lot of technical issues that they were facing that we can take it in the end. I think what I would like to take now is about the challenges that you face in pain management per se. Because in the end, we can definitely take about the course and the duration and the issues
Uh,
that you're facing.
okay, so like I'm coming from a background of DRTB. So I'm working with patients who are like dealing with drug resistant TB or co-infected with drug resistant and HIV TB. So I'm right now I'm not directly very directly, like I don't have like once or as an I'm a manager now, but I do see patients, and the challenge is like hesitancy of disclosing that we don't have any more treatment for TB, because which is curable, which is quite confusing. And secondly is the infection control along with the palliative care, which becomes very challenging because palliative care, most of them, it's cancer patients, non-infected patients. But in our setting, it's very different because it's infection control also a huge, it plays a significant part in, because MDR-TB, there's other family members also there. And like if the patient wants to go somewhere also, they cannot go because there's restriction because of the self restrictions and many things because of the infection control.
Yeah. So, Dr. Riddhi, I would like to ask you one important question. When you said it's infection control plus palliative care, so what are the issues that you face while you are aiming at palliative care for such patients, the MDR-TB patients? Do you face any kind of challenges while providing palliative care, basically, in and around the symptomatic care of such patients?
Firstly, like palliative introducing to TB patients, it becomes difficult because we say that it is curable, and in the beginning, but MDR patients, which are complicated, not every patient would be discussed as a palliative care. Like that is another challenge, because we are hopeful and it's curable, and the stigma along with it. But for in terms of when the patient is really like drug resistant, the patient has taken 2 years of treatment, it is not working, and he's still positive. So they are in the houses where they are not equipped with well ventilation. Plus maybe like when I was working in Mumbai, like the patients came from slum, like so there's no good opportunity for the patient, like for doing the ventilation for the family also. Even if they want to, they cannot keep the mask every time because they're already short of breath.
Yeah.
So
I would specifically want to know here, that the communication part will be dealt with in another module. So today
okay,
we are going to discuss, we are already
pain.
starting to discuss about pain management. So,
Okay.
have you faced any kind of challenges while providing pain management? Do you see patients who come to you with MDR, TB, or even when they are already cured, they have some residual pain? They are manifesting that pain. Have you
Yeah.
seen that kind of a patient?
So I have like two, but I'll give one example, which is peripheral neuropathy because of linezolid.
Yeah.
So it's a thing where they have constant burning of the sole, like foot,
Yes.
or more it is extended up to knee also at times, or numbness, or where sometimes they are not able to have the sensations also. So
Yeah.
like the tingling numbness is quite prominent, and that burning sensation, which especially in the summer it increases. So in that situation, like we give amitriptyline, but like it is also not completely helping the patients. So then we have to tell the patient that like you wear like you can put your feet in cold water for a while, or like some other things which might help them, something additional just to symptomatically, not completely, yes, we know that peripheral neuropathy, but just the burning sensation in that moment of time, like when they've gone outside in the hot summer, so they come inside and then wash the water, so
Uh,
those kind of things.
yeah. So,
And
could you please explain? I mean, I'm sure be able to explain why, tingling sensation or numbness or, the issue of peripheral neuropathy is very common in MDR-TB. I mean, many people may not be
yes.
in this particular setup or, as
Mhm.
I also want to know, I mean, can you please tell what is the pathology
Yes.
or just explain? Yeah.
Yeah. So for MDR-TB, we have a combination drugs. So linezolid is one of the important core drug which is added to any of the MDR-TB treatment or XDR, pre-XDR. So this becomes and the treatment is given. I mean, now it's different, like 6 months, 9 months, and the dosage is around like 600 mg. So different patients will present differently. Supposingly, if they have diabetes, they already have a baseline mild peripheral neuropathy, so they might present it early with losing. We test them with the tuning fork, so they start losing early vibration. So the signs. So linezolid is a drug which can cause peripheral neuropathy and also optic neuritis, and which is an essential core drug. So there is some kind of neuropathy. The grades vary with patient to patient, but there is always, they will have at some point of time experience the peripheral neuropathy signs and symptoms. And some patients have reached too far that it becomes irreversible, because peripheral neuropathy is irreversible in this condition due to linezolid. And then once it's reversible, the pain management comes into. So I hope this is.
Yeah, this is a very extremely important point, because we use linezolid in other other diseases than MDR also. So
Yes.
anybody else who would want to add to what Dr. Riddhi has said here, then I'll be able to start with the explanations and we can go on discussing. Anybody else who can just add to what Dr. Riddhi has said. Okay, so all right. So linezolid, as you know, it is also used for cancer. Okay, and we see, yeah. So the mechanism that it works is by it actually acts on the myelin sheath of nerves, and that's the reason why it causes a lot of neuropathic pain. Now, there is a point where, in MDR tuberculosis, you start linezolid. It is an important drug of the regime, and it goes on adding to the destruction of myelin sheath. And at one point of time, there is a destruction of the whole nervous system, the nerve which is involved, and that is the reason why peripheral neuropathy occurs. Now Dr. Riddhi has brought up a point where she said that the peripheral neuropathy that is caused is towards the malignant side or cannot be cured. Now here I would like to say that Dr. Riddhi, do you also use something else to add to to actually get rid of? Hello? Yeah. Do you actually use anything else to get rid of peripheral neuropathy other than pain medications?
So like we give symptomatically like vitamin B6 and gabapentin.
Yeah.
So those are the initially like, to prevent and prevent further damage.
So, yeah. So, along with lenazolate, we also use vitamin B6. Okay. And gabapentin that you're using, what is the dose that you use gabapentin?
So we start with the minimum dose first,
What is
and then
the minimum dose? How much do you start with?
75 mg.
75. Are you talking about
No,
gabapentin or
GABA. I mean, yes, gabapentin 100.
okay?
And
And
then we extended to like, but again, the availability of gabapentin is also limited and it's expensive. So, it becomes a challenge for patients sometimes to buy it also.
yeah. So, you see, the basic thing of managing pain, whether it is neuropathic or nociceptive or a mixed kind of a pain, the baseline would always remain the same. The basic principles of pain management is the same. When you assess the pain, you will come to know how much is the pain score, what kind of pain it is, what is the quality of pain. uh, you go back to the basics of starting with assessing the pain, and then asking the patient to at least pinpoint where it has started. So when you do that, you'll actually come to know how much of this medication is required. You have definitely zeroed in on peripheral neuropathy because of the nature of the medications that you're using. But having said this, let us also understand that neuropathic pain responds also to NSAIDs. So do you use NSAIDs?
Yes, we give them sometimes, but like, these patients also have a lot of gastritis, and so NSA, like, giving NSAIDs is like inducing more gastritis, nausea, and another issue. So like, generally we prefer, we can sometimes we give, but mostly like we start with increasing the dose of B6 and then going to gabapentin, and then we go to amitriptyline.
Yeah. So have you actually tried a combination of amitriptyline and gabapentin?
Yes, we do give that also.
So what is the highest range that you have gone, like what is the farthest that you have gone?
I don't think so. That in that, like, I've not gone that.
Right.
I don't remember to the maximum one.
Okay, fine, not an issue. But you do have patients who do not really respond to the dose that you're using. Is that
Yes.
so? And that
Also,
is
can be,
challenging,
yeah.
right?
Yeah.
Yeah, so that's a challenge. Exactly. So we will discuss about gabapentin. We'll discuss about peripheral neuropathy. I'm just parking it now, this particular challenge for a little later. But then, of course,
Okay.
if somebody else also wants to, share their challenges, let us have the pain thing first, and then we can proceed with a little bit of discussion. Anybody else who wants to give their problems, share their problems while taking care of pain management? I think somebody, Dr. Pankaj also had raised his hand.
Hello. Yes, ma'am.
Yes, Dr.
Dr.
Pankaj.
Pankaj here. Ma'am, about the constipation protocol which I have read in the module, it's showing the Apia S and Miralax combination, which is not easily available over the pharmacy counter.
Okay, so you're talking about constipation, right?
No, yeah.
I think that Dr. Pankaj, that will be dealt with in another module. So I can definitely explain that to you, but I think let us just park abdominal symptoms, constipation, etc. For another class. Will that be
Yes.
fine?
Yes, ma'am. Thank you.
Yeah. Anybody else who wants to discuss about pain, challenges in pain?
I think there is a comment from Dr. Krishna telling that whatever dose recommended for all these drugs can be quite challenging. For example, amitriptyline, we can go up to 100 milligram, but the compliance is poor and the patient complains a lot. Like the dose of pregabalin and gabapentin, whatever is recommended.
Okay. Amitriptyline 100, but compliance is poor. Okay. So, Dr. Krishna, could you explain what compliance is like? I could not understand where. Yeah,
Ma'am, can you unmute?
unmute. Dr. Krishna,
No,
unmute.
yeah, you have not
You're
unmuted.
muted.
Yeah, actually, whenever we prescribe amitriptyline, like you go high, the patient usually complains a lot, like giddiness, early morning discomfort, and that about to feel whole day they are feeling very drowsy. It's sort of that. So I have seen this one that they really do dry mouth and other, poor compliances. It inhibits us to go high.
Okay.
Somehow, I tried to go high, but the patient do not accept much.
So you are basically talking about the side effect profile of amitriptyline.
Yeah, and even not even palpitation and other things also, it comes after use of some time, like maybe say for example 2 to 3 months. The cardiacs, like they most of them they complain palpitation, some sort of discomfort.
So, may I ask you, what are the basic things that basic history, perhaps I would like to ask, you take for a patient before you put him on amitriptyline? What are the precautions that you might, think about before putting a patient on amitriptyline?
See, when we start very low, like 12.5 mg, 25 mg, we don't consider much. But when there is a plan to go high, in that case, we always see that whether the patient is aged and any cardiac abnormality underlying, that is, the QT prolongation like that, or there is some urinary retention history, aged prostatic problem, those sort of screening, usually it is done. But most of the people, most of the physician I have seen, without going through all those details, they start, but it is true. But whenever I have prescribed, I have seen that some discomfort is there. One of my patients, he really complained in the morning next day that the medicine you have prescribed has given me a lot of discomfort. I am feeling whole day drowsy, I cannot do anything. And though it was in many NTP in 10 mg doses, but this sort of challenge I face usually, start very low, but going high, to high dose, it really scares me a lot. So what is your experience?
Okay, so basically, when we start amitriptyline, as you rightly said, we have to first of all take into account the age of the patient. So any patient, above the age of 70, I would actually lower that to a comfortable level of at least 65 years of age. I would not want to prescribe amitriptyline at all because of the reasons that you have rightly cited: the QT prolongation, the urinary hesitancy part, the extreme dryness that might occur, and
Glaucoma also.
absolutely. So glaucoma would be a little later, but these are the immediate things that I would actually look after. So I will not actually choose amitriptyline at all for this particular age group. Secondly, for those who, amitriptyline is a wonderful drug, to be very frank, and it takes care of peripheral neuropathy in a in a much better way. When we didn't have gabapentin when when we were restricted to use gabapentin because of cost issues for our patients. Amitriptyline, was our savior because for at least for cancer-induced peripheral neuropathy or chemotherapy-induced peripheral neuropathy, and for that reason, MDR tuberculosis also. But having said this, you will first need to find out the side effect profiles, which is very, very important, and you have to if you do not if you do find out the side effect profile interfering with the quality of life of our patients, then uh, amitriptyline is a no-no. Okay, so having said this, I think now I can answer Dr. Riddhi's question of how we take care of the the peripheral neuropathy, which is because of MDR-TB and usage of linezolid. Since your patients are already with a lot of gastritis because of the nature of the drugs that you are using, we will really not use NSAIDs for them. Okay, but for a different group of patients, basically the oncological patients with little amount of peripheral neuropathy starting in, we can definitely think about non-steroidal anti-inflammatory drugs, which are the first step in taking care of peripheral neuropathy. And then we start with small dosages of amitriptyline. And amitriptyline, you should be actually starting at a lower dose, as Dr. Krishna rightly mentioned, and that would be 10 milligrams every day. And we generally give that as a HS dose or a bedtime dose, so that it induces little bit of drowsiness, and the other side effect profiles are also kind of masked when you use it at a during the night time. Secondly, the advantage of using gabapentin, instead of amitriptyline, is that the side effect profiles are not so much as in amitriptyline. But having said this, people with a little bit of maybe nephrotoxicity or some kind of difficult parameter in towards the nephrological side, where you see a little bit of creatinine being on the higher side, I would actually not recommend gabapentin to be used. So patients with a deranged renal profile, please do not use gabapentin. Instead, you should actually try and titrate amitriptyline at that point of time. For MDR-TB, Dr. Riddhi, I would suggest you to please make a cocktail of both gabapentin and amitriptyline for the peripheral neuropathy to be taken care of, because that has been actually caused by linezolid. And if you can also at one point of time, if it is actually interfering with the quality of life of these patients, and the course of the drug is beyond 2 years, I think there is a protocol to actually slowly reduce linezolid. I am not sure about this. You are the best person to judge, Dr. Riddhi. You can actually tell us about it later on. But as far as my little knowledge is concerned, I believe that after a certain period of time, when MDR TB actually becomes, goes towards malignancy, you might as well consider, withdrawing or slowly tapering down levosolid. And that's because, you may have to increase amitriptyline, you may have to increase gabapentin. But since it is a complicated kind of a peripheral neuropathy, it's always advisable to make a cocktail of gabapentin as well as amitriptyline and try it out for peripheral neuropathy. I think so injectable B12 and B6 works better in neuropathy in spite of oral. Okay, I haven't had a lot of experience with injectable medications while taking care of palliative care patients, because I would like to follow the basic rule of by the top, by the ladder, and by the mouth. So, oral drugs would actually always be a kind of rule to be followed while you are in palliative care. So maybe Dr. Krishna, you can, consider shifting to the oral drugs rather than injectable drugs. Okay. All right. Any other issues that you might, anybody else might want to?
Dr. Isha, you are trying to type something like I can read. We have a patient with CA colon post APR. Was there a question regarding pain management?
Yes, ma'am. Ma'am, I had a patient post CA colon underwent APR. Now with brain mets, and she had seizures also, and she presented to our department with pain at the site of colostomy site, and we provided antibiotics. And about the pain management, madam, I have a doubt whether tramadol is contraindicated in this patient. Is it, ma'am? Can you please
Dr. Isha, your voice is not really clear. Can you please again elaborate your problem?
Madam, we have a patient, a 60-year-old patient with a CA colon, underwent APR, and she had seizures also, and was diagnosed with brain mets. Now she's under our palliative care, and she had pain at the colostomy site, and it was written in the post-discharge summary to give her ultraset SOS, tramadol SOS. Tramadol contraindicated in this patient. Can you please discuss regarding the pain management for this patient?
Yeah, so you are talking about pain in the colostomy site.
Yes, ma'am.
And the patient also has brain metastasis.
Brain mets. Yes.
Okay. Is there any other thing that is going on with the patient? Any kind of vomiting or obstruction or anything else that the patient is complaining of?
No, madam. There was complaints of vomiting and decreased appetite, but there is no signs of any obstruction.
Okay. So is this pain continuous, or it is just yeah,
It is an intermittent type of pain.
intermittent type of pain? Is it incidental, or it comes because of some kind of a trigger that goes on? Is it because every time the nurse changes the colostomy bag, there is a pain? Have you inspected the colostomy site? Is it a clean wound, or is it healing, or?
It was a healing type of wound, madam. But pain mainly comes while moving. When she moves, only that pain comes.
Okay, so it is a movement related pain, right? Hello?
Yes, ma'am. Yes.
Yeah, it is a movement related pain. So movement in the sense that he gets up and he's out of the bed and he starts walking. That's when it pains, or it is something else?
While lying in the bed and moving, while getting up from the bed and while walking, at that time this pain aggravates.
Okay. Okay. So is there a baseline pain that you have, discussed with the patient? Has the patient told you, have you tried to find out the details of the pain?
Actually, we gave her paracetamol, a QID, and but it was not relieving, madam. So we considered tramadol, but with this brain mix, we are not confident regarding giving tramadol also. So we managed her pain with paracetamol QID, but there was only little relief of this pain.
Okay. So you
So we
have,
are confused what to start next.
yeah. So you have started with first step of the step ladder, right?
Okay. Yes.
But that is not taking care. So you escalated to the second step. You started with tramadol. That is also not helping, isn't it?
But the tramadol we started, madam, but I'm confused that brain meds is tramadol contraindicated in this patient.
So
He had a
why do you
history
think?
of seizures also.
Okay, Dr. Isha. Okay. Tell me one thing. Why are you confused with the brain mets getting interfered with tramadol? I want to know that from you. What is the confusion that you have here?
I'm confused that tramadol causes seizures.
Sorry, come again.
He had a previous episode of GTCS because
Exactly. Yeah, you are absolutely on the right track, Dr. Isha. So tramadol should not be used in brain mets. Okay, because it actually precipitates seizure. And when you have a patient with brain mets with or a patient who has already a history of seizures or GTPS, then you really should be avoiding tramadol. But having said this, not all opioids will interfere with seizures. Okay, it is not going to. So brain mets, you are going to take care of the brain mets on a different vertical, and you're going to take care of the pain of this patient on a different vertical. And at the same time, you're going to avoid tramadol for the seizures. So when you avoid tramadol, do you think you can use morphine here?
morphine also the metabolite causes seizures. No?
Sorry?
The metabolite of morphine also precipitates seizures. No?
So is it like
But the patient,
yeah? Tell
we
me.
actually, madam, we start morphine only when the pain is very severe. But the pain
Yes,
is not
I
very severe.
I
It is
understand that.
only
I understand that. But when the pain is not severe also, and you are not able to put the patient on tramadol, then what do you think you should be using?
that is what my doubt, madam.
Okay. Can you use morphine in a lower dose?
Yes,
Okay,
ma'am.
let us look at a different scenario. Okay, let us look at a different scenario. There's this patient with hepatic meds. Okay, let us put aside liver mets. Let us just imagine that your patient has hepatic mets and he has clinical jaundice also because of the meds. Okay. But the patient is not responsive to any other step 1 or step 2 drugs, and you want to actually, put the patient on morphine. Now, how will you justify the use of morphine in patients with liver mets plus clinical jaundice? Can you use it?
Yes, ma'am, we can start using.
So what is the principle of usage of morphine or strong opioids when you use when you have liver mets along with jaundice?
It's a double-edged effect. Double effect. We have to
Sorry?
consider.
Sorry?
टाइप करके बोलो चेक नाउ बोलो टाइप करके मैम कैन वी यूज पेन कॉन विद टच
Hello?
I'm not getting the answer, ma'am. Can you please?
Okay. So see, when there is liver mets or there is a renal parameters falling down, you can actually use morphine in a lower dose, and that lower dose is actually 1/4 of the normal dose that we use. Okay.
Okay.
If you think that because the metabolites are going to be accumulated in liver failure as well as kidney failure, but you do not have any other option but to use morphine, and at that point of time you use 1/4 of the total dose. If your patient needs 10 milligrams, perhaps 60 milligrams of morphine a day for the pain to be responsive, you do not use 60 milligram, you use 1/4 of 60 milligrams as a total dose. And then you can actually divide it into smaller dosages in a 4-hourly or even a 6-hourly basis. And the patient is going to respond to that. Yes, Dr. Chandrika said, ma'am, you can use fentanyl patches. Absolutely, we can also use fentanyl patches. But then Dr. Isha's patient doesn't have a constant pain. It is a movement related pain. So when it is a movement related pain, you will have to anticipate the movement and then give the painkiller to the patient. Okay. You know that the patient is going to go to the bathroom, and when he gets out of the bed, he's going to have that movement related pain. You give a smaller dose of the painkiller just before, maybe 10 to 15 minutes before going to the bathroom or going for that major particular thing. Okay. Dr. Isha, did you get my point?
Yes, madam, I understood.
Yeah.
Now,
So these are the issues that we are discussing right now, and I'll go for a proper presentation also. I have some case scenarios, but it's really good that you all are coming up with your issues. And anybody else who want to give their problems, anything else? Anyone else? Okay. So Dr. Adra is saying, why not to immobilize the patient? Okay. So, I would not really want to get immobilized and confine myself to the bed if I am the patient. Dr. Adra, is that an explanation that you are satisfied with?
Yes, ma'am. I just wanted to know whether it is advisable to immobilize the patient, or should we go for the medication? Like, what should be done? Like, what is the protocol?
Well, there is no protocol. You need to ask the patient whether
Patient's wish.
what
Okay.
what actually will make him happy. The first and the foremost that he will say is that I want to get rid of my disease. I want to go back to my youth. Okay. Interestingly, this happened very recently with my father. My father is a CA prostate patient, metastatic CA prostate, and he has been doing perfectly fine with all his medications. But yet he wanted to, he wants to go to the oncologist over and over again. And at one point of time, his oncologist actually asked him, why do you keep coming on to me? You are absolutely fine. So my father said, no, I just want to get rid of my disease. So maybe this patient, if you ask, he might as well tell you that I really want to get out of my disease. So yes, we would not actually want to immobilize the patient, but then treat the symptoms that's actually coming out. Okay. So I think we have not much time, but I really want to discuss other things. So I'll just share my screen, and we can along the way, like we can actually discuss with some other issues. So can you see my screen?
Yes.
Okay. So you know about peripheral sensitization. These are the pathophysiological, changes that occur when there is a trigger at the peripheral nerve. So all these mediators, they come into play. There is the sensitization of the peripheral nociceptors, and at this particular point of time, when we use NSAIDs, it definitely prevents other pain producing substances from getting secreted. And if you do not use, do not block the peripheral sensitization, there would be other, nociceptors which are actually silent or sleepy nociceptors. They get recruited. Generally, they are called sleepy because they are sleeping all the while. They're not disturbing anything. But then when there is a sensitization which is not treated, these sleepy nociceptors, they come into play, and then they are also very much activated inside the inflamed tissues. So that's a kind of a peripheral thing that happens on in and around the peripheral nerve. But as the treatment is not there, you do not treat it, you do not block the sensations, it actually goes up to the central nervous system. Not going into details, but I believe that you have already gone through this in your modules. So central recruitment would actually bring about malignant changes, just like this, the MDR TB thing. It is kind of a secondary hyperalgesia, and also okay, I'm not going into these details. Chronic pain, you already know about this, I feel. So this is a case that I really wanted to discuss with you. So he's Salim. He's a 33-year-old male. He is diagnosed with cancer of the left mandibular alveobuccal complex. He has been referred to you for pain management. He's complaining of severe pain at the left side of the face and neck. So there is a prominent swelling of the left jaw, resulting in difficulty in swallowing. There is a sericity of the face being done, which has revealed some post-treatment changes with destruction and lytic areas in alveolar process of the mandible. There is a fracture also. There is soft tissue thickening, bulky heterogeneous left masseter muscle. It was suggestive of post-treatment osteomyelitis and a pathological fracture of the left mandible with residual disease or recurrence of the cancer. Now, the patient complained of oral ulcers on the left mandibular gingiva for last 1 year, He was diagnosed with squamous cell carcinoma of the left mandibular alveolus. He underwent commando surgery and post-operative radiotherapy for around 6 weeks. He was under regular follow-up with the surgical oncology team, but suddenly he started complaining of pain in that particular area. So the CT scan had confirmed a fracture in the left mandible. He was given diclofenac tablets, which overall seemed to control the pain to some extent. Now, I want answers or your opinion on how you will evaluate this patient. See, I write evaluation because once you are a master in evaluating a patient's pain, you are absolutely on the right track to give him the best treatment. Okay, so can I have some of your inputs? How are you going to evaluate this patient? You can unmute and talk also, or you can just put your responses in the chat box. Yeah. So we have a chat. Okay, so it's a Dr. Chandrika said subjective methods like VAS score. Okay, and start with eliciting pain characteristics. All right. Then anyone else? Okay. So this is what we will generally, start with, taking the pain history. It's similar to that of the general history that we take for a patient when we first get a patient. Okay, taking the chief complaint and asking for his personal history, his family history, then the zeroing on in the chief complaint the history of since when he has been having. So pain history would be in this particular manner, OPQRST. So you know this. Maybe if you remember OPQRST, I think that would actually give you a proper kind of a protocol to actually approach the patient. Okay, so you do that, and so you are now assessing the pain for Mr. Salim. So he said that the pain was gradually increasing in intensity since the last 1 month. It was severe, throbbing, and unbearable in nature. So as somebody said about the VAS score, it is 9 on 10. The visual analog score for this patient, he said it is 9 on 10. It is not relieved with weak opioids. So he has given you a history of previous medications that were used, okay? And perhaps he has actually given you a history of using tramadol or Ultracet, even tapentadol, okay? So these are weak opioids that has perhaps been given to this patient, which was not working. And it increased on stretching of facial muscles and prevented the patient from talking, eating, and brushing his teeth. So there was tenderness over the left mandibular region. Patient was not able to sleep for past few days due to the pain. Now, what is your diagnosis regarding the pain? We need to zero in what kind of pain it is. What is the diagnosis? What is it? Is it a bone pain or is it a nociceptive pain? How do you actually do that? Dr. Manglik, you are absolutely right when you said type of quality of pain. Absolutely, yeah. Okay, Anju, Dr. Anju says it is somatic pain. Dr. Manglik again says it's neuropathic pain. Yeah, okay. And anybody else who wants to just put in their opinion? So, yeah, somebody else. Okay, somatic pain. Okay. All right. So, so how do we actually diagnose a pain? So by looking at the quality of the pain, okay, whether it is a nociceptive pain or a neuropathic pain, that's a broader kind of a, uh, differentiation that we have to have. Okay. Uh, Having said this, in oncology setups, we have more than 50% or even 60%, more than 60% of our patients coming to us with mixed type of pains, which is both nociceptive and neuropathic. Okay. It is always advisable to, assume that the patient has a part of pain being nociceptive when you are actually diagnosing the pain as a neuropathic kind of a pain. And it is vice versa, because if you, diagnose the pain to be a little bit of nociceptive in character, nociceptive in quality, then you should assume little bit of to be neuropathic also, a part of the pain to be. So it's kind of a mixed kind of a pain. It is always going to help you out in actually, giving the right kind of medication. Okay. And then, of course, not to over medicate also. All right. So nociceptive pain is wound-like, it is aching, there's a gripping sensation. But then when you say neuropathic, you do have, kind of a numbness, lancinating pain, shooting kind of pain, feeling of a raw skin when you have actually burnt your hand or part of your body, and that raw skin is exposed. The kind of feeling that you have is the kind of that's a neuropathic kind of pain. And then chilies being rubbed, burning sensation, a bag of worms, crawling of ants, prickling sensation, pins being actually pinched on the skin. So those are the quality of a neuropathic pain. We have some responses in the chat box. Somatic pain with some infection to be ruled out. Okay, so yeah, and we'll come to the infection part also. Dr. Chandrika actually mentioned about the mixed pain, and Isha, pain due to the fracture. Absolutely, absolutely. You already have a proper history of mandibular fracture, a pathological fracture, which is actually going to give him a lot of problems because we are not in a position to fix that, in the mandible. Had it been in the long bones, in the humerus, in the femur or anywhere else, we could have had a kind of a thing in place to take care of that. But in the mandible, it is really very difficult. Okay, fracture and osteomyelitis, absolutely yes, right. So, so now we come to the intensity of pain. See, you assess the pain, you find out, how much is the pain score. Okay. The pain score actually gives you the intensity of pain. The intensity of pain will guide you which medication to be used in what dosage. Okay. I'm sure you have already gone through all these things. I'm just revising things with you so that, I also read, I also can study with you. So these are the pain assessment tools. You already know it. The VAS is, given by the numerical pain scale. The Baker is usually we use it for children. The 5-finger scale is also a very useful scale. And many times I have also used the coin scale, out of 100, 100 पैसा में कितना pain है, or out of 1 rupiah, how much pain you have. The patient actually tells you. It's the villagers, those with low education, they actually tell you ki it's 75 paisa or it's 25 paisa. They actually tell you. It's very interesting. And then these are detailed assessment, which I will not now go into. You can see these are the assessment tools. So you assess the pain, you came to know, and then it's very, very, pertinent to actually put that thing on a body chart also. You can ask your patient to do it. He will show you where the pain is. He is very intelligent. Even a child can do it. I've seen so many children actually pointing out. They will just color that red with a red pen. They will just color it. So you can do it also. And that is actually going to help you in the long run when you reassess the pain, because you just cannot, assess the pain today and sit back and relax for next 10 days. Okay. The pain is always a dynamic kind of a symptom. It will sometimes be very high. It will be, you can expect that with your medications, with your interventions, it's going to be on a baseline. But having said this, the baseline would be maintained, but there might be some spikes, which we call as incidental pain or a breakthrough pain also. Okay, just like, Dr. Isha actually gave us her example of a movement-related pain. The patient is all right when he's on bed, but when he gets up to go for the loo, or, when he moves on the bed, there is a movement-related pain. Okay. All right. Then, of course, how to manage the pain. Basically, look for the cause of the pain. In Dr. Isha's case, the main pain had occurred in and around the colostomy area. Okay. Although it is, it was healing, it is a healing thing, but still, when there is a movement, there is a pain. So look for the cause of the pain, and then you correct the correctable cause. All right. I have written here a few causes like irradiation, chemotherapy, surgery. There can be many other causes also, which, when you look for it. So you make a protocol for yourself for the pain. When we write the pain history, assessment, and review, we have a proper kind of a flow chart. You can make it according to you. There is no nothing like, you have to go in that manner or that thing only. You can do it according to your convenience also. And that must give you a thorough information of how much was the pain, what is the pain now, do you anticipate any changes in the next few days? Okay. If it is a malignancy which is related to a major organ, is the pain going to be increased in the next few days because the patient is incurable? Or if it is a curable kind of a disease, for example, a complicated, osteoporotic knee, right? That is not a malignant kind of a thing. It is, the knee can be taken care of by maybe a total knee replacement. But then till the knee replacement happens, the patient is having pain. So how do you take care of it? Okay. So these are the things that you need to look for. Okay, the very basic things, you can remember them at the tip of your fingers. So just make a flow chart for yourself. Okay, that's going to give you a proper, kind of a management protocol made by yourself and adaptable by to your setting also. Okay, so this is the basic principle, and then you first always think about the non-pharmacological methods, right? That is that should always be on the upper hand. There would be many non-pharmacological methods that you can actually think about for your patients, right? I think Dr. Adra actually told about, why not immobilize the patient? That can be a non-pharmacological method of, giving relief to that particular patient for a little bit of time till we find, till we actually take care of the baseline pain of that particular patient, right? So, and then of course, there'll be other things. For example, for this particular patient that we talked about with the knee pain, who's actually waiting for a total knee replacement, we can actually immobilize the knee joint, right, for some time. We can use cold compress. So think about non-pharmacological methods which you are able to use for your patients, in your own setup. For example, I think Dr. Riti has been following with asking her patients to dip their soles in cold water. That's an excellent method of, giving a non-pharmacological kind of a process, intervention to that patient. There's something in the chat. Okay, so immobilize the patient will lead to psychological trauma and patient cannot come out from the illness. I do agree. So Dr. Chandrika, what I meant by immobilization is that, we do it for a very little period of time till we get a proper solution through pharmacological methods to give relief to this patient. We can actually, give this immobilizing idea to this patient by, communicating properly the sole aim of doing that. We can actually tell him that it will be really nice if, you can lie down still for some period of time, maybe another half an hour or so that the pain is not disturbing you. And we are, on the process of finding out a better solution of how to take care of that. It's a mix of your communication skills. It's a mix of the methods that you're following. And of course, taking the patient always into that particular discussion. You're telling him that I am trying to find out this thing, but I would want a help from you, and the help being that, you lie down still for some amount of time. Yeah, we have some other chats also. TENS, absolutely. TENS is a non-pharmacological measure, and it's a very good, thing. Cold compression on the face, facial muscular exercises. Yeah, for this patient that I have brought out, muscular exercises may not be really very apt because he's already has been having a lot of infection also. He may not be able to, move his face. Exercise his muscles of the face. But then, yes, cold compression is a very good technique. It's a very good thing. Can we ask to apply any cold compression? Yes, we can. Actually, Dr. Krishna, we we really ask, we are much more into cold compress in cancer rather than hot compress. It is, there is an evidence that hot compress in, malignancy actually leads to more of the malignant activity of the cells. That is the reason there is scientific evidence. That is the reason why we ask patients to, use cold compress. So you can definitely ask your patients to use cold compress also. Yeah, so we were talking about these methods, and then, by the law of protocol, we come to the pharmacological methods, and then think about interventional techniques. For example, you have a patient with cancer of the pancreas, and we all know people who are working in cancer setups. You might have, seen patients with severe pain due to cancer of the pancreas. And when we do a celiac plexus block for such patients, there is a tremendous amount of difference that you'll find in the compliance of such patients, and the way that they get relief. It is a relief to the palliative physician and the treating oncologist also. Okay, it's a different issue that might not be a permanent kind of a solution because of the nature of the cancer. It might later on again overtake the patient. But having said this, a combination of all these treatment protocols, non-pharmacological, pharmacological, interventional, would actually be a very good kind of a treatment for such patients. Okay, so not going into details. So please do always try to follow the WHO analgesic ladder. It's a great guidance. It's going to give you a lot of relief from your confusions of which drug to use and which not to use. But you must actually start from assessment of pain. When you start with a proper assessment, you zero in on the diagnosis properly, you know that you are on the right step of the. So we use paracetamol, NSAIDs, like aspirin, ibuprofen in the first step. There would be codeine in the second step, tramadol, and many other drugs. I'll be coming there. That would mean plus minus a non-opioid, and the non-opioid, you can use a paracetamol or an NSAID with step 2 drugs. Okay, it's always actually better to use a combination of drugs. All right, a paracetamol in a lower dose would actually try to maintain or take care of the baseline pain to a larger extent. When you have patients with bone pain, for example, a metastatic CA prostate with lot of skeletal mets, they do have a lot of bony pain. All right, and you can ensure a good pain relief with 1000 milligrams of paracetamol every 6 hours. The highest dose would be definitely 4 grams per day. So you can actually use that as a to take care of the baseline, and then top it up with a mild opioid like tramadol. I generally do not use tramadol in a higher amount. Do not go beyond 200 mg every 24 hours. Rather, I would actually, shift my patient to a strong opioid in a very low dose. That works a lot. But then, before actually going to the step 3 drugs, it's very, very advisable to stick on to the adjuvant drugs, okay, which are steroids, which are antidepressants, convulsants, muscle relaxants, antispasmodics. That is the reason why I always, try to assess and diagnose my patient's pain and pinpoint it. Okay. If there is a patient with, just like, Dr. Isha had, this patient, I'm sure, must be also be having a lot of spasmodic pain also because of the obstruction. He's a patient with CA colon also. So, there would be some little bit of spasms that goes on inside the blocked intestines. Okay. There might be some foci of sparsely distributed spasmodic pain, infection, so it's always better to anticipate what might happen according to a particular diagnosis also. Okay, so these things, I think it's important for you to properly investigate, properly jot down the information that you get from each patient, and then, come up to a kind of a protocol, a tailor-made prescription for a patient like this. Okay. All right. These are the medications. I'm sure you know. Basically, please do remember using adjuvants because, antiemetics, antidepressants, anticonvulsants, muscle relaxants, these are very important and adjuvants. Corticosteroids have a huge role to play in palliative care. I would like to now come back to the patient with MDR tuberculosis with, linezolid. Dr. Riddhi, you can actually start using a little bit of corticosteroids for your patients also. Okay. That will also be very, very helpful in taking care of the tingling and numbness, which you were not able to take care, right? But having said this, please do remember to review the patient's pain, the baseline pain every day. Every day should be the protocol if he's admitted in the in your facility, or otherwise, yeah. So yes, Dr. Mangalik, you're very right. We do use baclofen 10 mg for muscular spasm. You can also increase it. Baclofen also takes care of hiccups. Hiccups are very, very annoying for the patient, and it actually, adds up to the pain. So those you can actually use. Okay, and with IV drug for acute pain management, IV fentanyl not available. If we talk about acute pain, Dr. Isha, fentanyl IV, we generally shift to fentanyl only when, morphine is not available. Okay. It's very easy to use. Morphine is very easy to use. You can titrate it in a very kind of a very local condition. For example, you can do it in your OPD. Okay. fentanyl might be a little problematic. So it's always better to titrate your patient on morphine first, then convert it to fentanyl if at all required. Okay. And for acute pain management, please, I'm sure you're going to have a opioid class in your next session. And that would actually give you an overview of, IV morphine trial, which is very, very important when we talk about acute pain management in palliative care setups. So IV morphine trial is, kind of the gold standard to take care of acute pain, as well as find out whether the pain is opioid responsive or not. And at the same time, titrate the morphine dose for that particular patient. And later on, of course, we can actually talk about, think about shifting the patient from morphine to fentanyl. Okay. All right. Yes, steroids definitely for inflammation. It's, the mechanism of action of, pain management by steroids is by reducing the peritumoral edema. Okay. And anywhere like, inflammation is taken care of by steroids. And we use dexamethasone because it has a lower mineralocorticoid activity. Okay, so Dr. Chandrika has said we get the details of drug with per kg dose of pain management and also mechanism in detail for pain relief. Okay, yeah, definitely. I'll try to give you that. I mean, I can actually send it to you through Pallium. So tab block is beneficial for. Okay, what is tab block? Is it Dr. Chandrika, can you tell me what is tab block? I don't know. I mean, tab block. Okay. Transverse abdomen. Yeah. Yes. Right. Yes. Okay. So I'm not much into, dot things. So sorry about that. We can definitely do that. Yes. Okay. So we require an opioid risk score. So how do you do a opioid risk score, Dr. Mangli? Could you please explain it to us? I'll definitely come to that, but if you could please tell us how you do a opioid risk score. You can, yeah.
Good evening, everyone. Actually, during this self-learning session, I saw that there is an opioid risk tool for everyone before starting the opioid, because there are many cases of substance abuse. So actually, that was a question. Should we require opioid risk tool here also? Because the patient told us that in the history we saw that he took some opioid also, and he didn't. The pain relief is not much. So in opioid risk tool there are three types of risk factors: low risk, moderate risk, and high risk. So should we require that, or we can start from the beginning, that after by step? That's the thing.
Okay. So just to simplify what Dr. Mangling has said, it's very important. It's an important thing that we understand where we need to find out an opioid risk score. So if your patient is a substance abuser, has a history of substance abuse previously, okay, that is where you require a opioid risk score. and not anywhere else. Okay, please do not complicate it, because this particular patient that we have discussed about, this patient is a cancer patient. This patient was prescribed weak opioids at one point of time to take, to manage the pain of this patient. And he was not abusing himself on opioids. Okay, so please understand the difference between these two things. Okay, so please separate these two things. Do not confuse, do not mix. We will require a opioid risk score for a patient who is, who has a history of drug abuse, all right, and not anybody else. So that is where the opioid risk score comes in. Okay. Alcohol history. See, alcoholism and a patient with a kind of a lot of drug abuse, both of these things are different. Although, these are all abuses only, but alcohol history would be more pertinent for a patient who has a pancreas problem, or a cirrhotic problem previously. Okay, alcoholism might actually precipitate seizures. Okay, and also might lead to some kind of a alcohol withdrawal syndrome. Okay, rather than patients, both the things are actually different. The drug abusers would be a different thing, the alcohol history would be a different thing, and when we talk about opioid risk score, it should not be confused with alcoholism at all. That will be a different thing altogether. Okay, right. And okay, which is better for continuous pain, opioid patch or oral opioids? Okay, so this is Dr. Chandrika. Okay, Dr. Chandrika, as we've seen, the basic rule that you should follow while you take care of chronic pain or continuous pain for that matter is by the mouth, that is oral medications. By the ladder, that means you go step by step from one step to the other to the third step in the WHO ladder. And the thirdly, by the clock. That means when it is a continuous pain, you have to provide the patient with continuous analgesia. Now you've asked about a patch and an oral opioid medication. So I would prefer to find out whether my patient is opioid responsive or not by doing a IV morphine trial, or you can also do a oral morphine trial, find out the actual dose which is required, put the patient on morphine which is titrated, which you have found out, and then when the patient is properly stabilized for a long period of time, for example, he doesn't have any kind of instability while having the medication, instability in the pain. For example, he doesn't have to take rescue doses. All right, you will be getting a proper explanation in your next opioid class, but still, since you've asked this question, I'm just telling it to you. So when you do that, you find the patient is stable on a particular dose, for example, 10 milligrams of morphine every 4 hours. He doesn't complain of pain when he is on 10 milligram every 4 hours. And you observe that for around maybe another 4 or 5 weeks. Then you decide that, okay, now I'm going to, the patient actually comes back and tell you that, doctor, now I'm fine. Is it important that I always take this medication every 4 hours? Orally, it becomes very problematic. Then you think about switching, from oral to a transdermal patch. And transdermal patches are has to be equivalent of both. For example, you cannot put a patient who is on morphine to somebody with something which is lower, which is perhaps buprenorphine. There are buprenorphine patches available. So you can't put patient on that because the potency is not the same. But you can definitely think about, putting the patient on fentanyl transdermal patches. Okay. So these things would be, better explained when you attend the next class. I think that would be a thing. Okay. So Dr. Priya is asking how to do the detailed pain assessment in non-verbal dementia patients. Okay, yeah, that's a very important question. You see, you'll have to actually come back to the facial expression when you do a pain assessments for pediatric patients. So kids are not able to tell you how much they have, what kind of pain they have. Even for infants, you do pain assessment. Okay. So this is absolutely replicable when you talk about dementia patient, which are non-verbal. They do not. But they will show you facial expressions. They will have body language that, gives you an expression of, Dr. Manglik, right? Wong-Baker Faces Scale. That is absolutely right. But Wong-Baker Faces Scale is also, it is a subjective thing because the kid is actually showing you with his finger, which is the face. Is this your face? Yeah, Shri Priya, I'm just trying to finish it off. I don't think we can go to the ethics part, but then we'll finish it off very soon. Thank you. So Wong-Baker Faces Scale is a kind of a direct thing by the kid itself. So you cannot actually relate because here the demented patient will not be able to show you, point a finger on that particular face. Okay. So you will have to find out what kind of faces the patient has. Is it grimacing? Is the patient grimacing? There are certain assessment tools for that also. And that is a little specialized. So I'll not be talking about that today. Maybe later on, you can have that on a different class. Okay. Yeah. About this scenario. Okay. How to assess the pain in patient with plaster in the fractured limb? Okay, it's the same thing because, the limb is fractured. You've already plastered it or kind of fixed it, So maybe you may not, the patient may not actually complain of pain. That is one. Number two is that, the assessment criteria for any patient would actually remain the same, except for special patients like those that Dr. Priya just mentioned about, yeah. Okay. All right. So, so this is about the WHO ladder. So you kindly go through this and you need to understand, you need to know about which NSAID works in what context. So you will have to find out ways and means of giving medications to these patients. So I'm not going into all these details. I'm sure you know it. So also take care of the potency. You will always be talked about potency. Okay, Sri Priya, do you think we can actually go to medical ethics today?
Ma'am, we would have loved to, but I think we have the technical person also logged in. So if the participants are having some more queries related to technical things, maybe.
Yeah,
But
yeah.
it is the
I
final
think
call is from you and Sridevi ma'am. So
yeah, we can just I can just stop. I think yeah, but definitely I think there was a lot of discussion today, so it's been really nice.
Yeah, that's the whole purpose of this session. It is to basically discuss the case, because in the self-learning modules, they'll be anyway learning the theory part in depth. So it is about asking what happens in the practice when we deal with such patients. So yes, it was at the right place. Mahesh is there, right, Sri Priya?
yes, ma'am, he has joined. So I think one question we had from Dr. Krishna regarding so I can just read out for him.
Sorry, Sanghamitra, I'm so sorry. This may not be little out of context for you. They'll be asking more of a technical things to the technical expert because of the self-learning module platform. If you are,
I think I can actually log off if you permit me.
yeah, sure, sure. And thank you so much for the discussion, because that's exactly what we want for the session. We wanted them to ask questions and learn from the expert. How do they do things on the ground? Thank you so much for
Thank you so
sharing your
much.
experience.
It's been really wonderful. I actually really didn't realize we have crossed at least so much of time, Thank you so much and sorry for taking so much of time.
No problem.
Okay.
Thank you, all the
pleasure
participants.
having you with us, ma'am.
Thank you, Shrutia. Okay, bye-bye. See you.
Yeah, thank you. And all the participants, if you have more questions, please send it in the WhatsApp group. We'll be happy to get back to you. I mean, constant, like whenever you are stuck with any patient, that's the whole purpose of the WhatsApp group. Please send your queries to the group. One of us will be taking it up and getting back to you with our experience sharing. Over to you, Sri Priya, and technical team.
Thank you, ma'am. Mahesh sir, hope I'm audible.
Yeah.
Okay, so we had one query from Dr. Krishna, like it was actually she, just a moment.
Yeah, I got the question. Today I started doing paid module 3, saved my but my activity was not shown. So first thing we would like to recommend is that use the Windows platform and Chrome browser. So we have some known issues with the other platforms in the Mac, iPad, and all the things. So Android also. So that is recommended. So if you can try it out in the Chrome browser in the Windows platform, that would work fine. If you are facing any issues, and while reporting any issue, we would recommend it to have the screenshot so that we can understand it faster. So you can post it in the group so that we'll respond it faster and fix the issues if any. So I think most of the people are okay with it. There are some minor people, some with some technical glitches. So we are working on it for other platforms as well. But right now we would recommend Windows platform with Chrome. That's it.
Thank you, sir. Any other pressing questions, concerns which you are facing with the LMS platform? You can ask now.
So I want to ask one thing, that whatever activities I did today, that was saved, but it is not showing. So do I need to give that test, do that module again?
Can you send me the username and password so that I can check from my end if what is the exact the issue is?
Okay.
Okay, you can share me separately so that I can log in and check what is the exact issue, the status, so that I can tell you whether we need to repeat the module or just continue
Because
it.
whenever I'm trying to go back, I'm going to the same quiz. I mean, last, the test section, I cannot go back to the activity part again.
Okay,
So
can I know which platform are you using? Is it Windows
uh,
based?
it's
Chrome?
window only because I was doing from my office desktop.
Okay.
So I was using, yeah, it was window only, not through phone or some other thing. So maybe I have to do it again and I can send you the screenshot.
No, I
Right?
no need to do it again. I think first you can send me the screenshot. Let me check from my side. Then I'll
Okay.
inform
Okay.
you.
Okay.
Okay.
Okay. Then I'll send you.
Okay. I think someone else has also messaged me with the issue. I think let me just check. Mm, Kushi. Is Kushi here?
No, sir, that is another best global.
Okay. Okay, fine. Okay, then so you can put whenever you have issues, just get the screenshot and post it in the group so that we can solve it faster. So we can, because some people may say that it is not working, but when we don't understand what is the exact issue, if you say that it is not working, so it might be a module issue, it might be something else. So to understand it better, the screenshot would be helpful for to it would make us understand faster the issue. That's it. Okay, so
Okay. Thank you.
yeah.
Anyone else have? Yes.
Okay, so I think if we don't have any further questions, over to you, Shri Priya. Yeah.
Thank you, my sir. Thank you.
Yeah.
Thank you everyone for joining today. We really hope that this session was very fruitful to you in understanding more about pain management, and with the promise that we will meet again in the next live session with more interactive discussion. This is Ripriya signing off from the Pallium India Specs. Till the time we meet again, everyone take care. Bye bye.
Thank you.